Hi, Laurie Sullivan here from Melbourne, Australia. This is a routine DMEK case. I just want to show you my technique. This patient had pseudophakic corneal edema and best corrected vision of 6/24. Here you can see me marking what I think are reasonable margins for stripping the host Descemet's membrane, and that's at about an 8mm zone size. Usually I choose a graft which is slightly smaller than that at 7.5 or 7.75. Next I'm going to mark the donor Descemet's membrane with an ink mark. I usually use an S stamp, which is a bit more regular than my shaky hand here. And you can see I've written an F there for front, so that inside the eye the F should be facing me and not reversed. Punching the donor, carefully removing the punch, and that was a 7.75. I'm now staining mainly the edge of the graft there with the Vision Blue, Trypan Blue. After I've filled the well with balanced salt solution, I strip off the peripheral Descemet's membrane, leaving behind just the donor where it's been trephined. Now carefully stripping off the donor, making sure to observe the edges are not catching, and the donor material scrolls up, and I'll just leave that in the well for now. I'm restaining it, and we'll then go away and strip the host tissue. Here you can see the donor tissue in a BSS filled glass bowl, and I'm just getting my goiter apparatus ready to draw up some fluid BSS fill the apparatus, and then to aspirate the graft into that glass tube. Sometimes I go in easily and sometimes they're a bit of a fiddle to get in. Now I'm attaching a pre-filled 3mm syringe to the posterior end of the modified Jones tube, and just looking at the conformation of the graft within that glass tube, you can see the reversed F there, which indicates that it's endothelial side out. After pushing and pulling the column of fluid and the graft, I can see that it's made a nice double scroll, so I'm then inserting the injector into the shallow AC and making sure that I rotate the injector so that that double scroll is facing upwards when I inject it. It's nice if you can get it into the correct position from the get-go. Unfortunately, I'm running out of BSS here, and to free the graft from the tip of that glass tube is not always easy. Just shallowing the chamber there, and it's still caught, and I'm just going to inject the air that's in the tube to help free it from the tip of the tube there. Very slowly withdrawing that tube and very gently placing some BSS in the anterior chamber. Careful, of course, not to pressurise the AC or the graft will shoot out through the wound. Need to make that bubble go away, so I'm just aspirating that. Sometimes a small bubble can be helpful to help unfold the graft, but in this case I'm wanting it to be gone or as small as possible. You can see I'm repeatedly shallowing the AC and checking the positioning of that graft as best I'm able to ascertain. Now I'm just nudging it into the central position. It is nice to have the graft scroll perpendicular to the wound, so it's less likely to come out. and I'm just gently tapping to encourage it to unfold. Now I'm holding one end of the graft and tapping along, and you can see now it's unfolding with that tiny bubble behind it. Again, shallowing the anterior chamber when need be. Just recentering again, and I'm really pretty happy with how that looks, just holding the graft steady and then letting some fluid out through the paracentesis, and that draws the edge of the graft towards the paracentesis. It's not quite perfectly centered, but it's pretty good. Now I'm going in with a air cannula right on top of the iris and just injecting an air bubble under the graft. Not forcefully, just allowing it to flatten out against the posterior host corneal surface. I can see the F stamp, which is upside down but not reversed, so I know that the graft is facing the right direction. And just filling up the AC with a SF6 gas bubble now, and that's the operation.